My favorite president's forums, and I think, when I reflect on the topic and our new capital campaign for the Families Are First Birthing Center, the miracle of birth and life is, and for all of you who have been there and witnessed a child being born, is probably one of the most incredible things. If I reflect back on my life of many years, seeing my child come out and just the whole incredible experience, and obviously what follows that is a long, road of childhood, all that stuff, and now for my kids, adulthood, which still remains with its challenges. It's just something that is so critically important to everyone and our community and our hospital, and it's been an absolute steadfast part of who we are. We're just under 600 deliveries. We have this extraordinary team of OBGYNs and other nurses specialized. It takes, I don't know if you know this, but how long does it take? Like almost a year for a new nurse to actually, who's coming out of college, coming out of their program, to actually learn. And if you think about it, you think about that split-second complication that occurs and the awareness and the skill and the knowledge that the nurse has to have in that split second, because minutes count. It's just so vitally important. And there's been, a lot in the news lately about maternity, births. Unfortunately, our country has an incredibly poor record of infant mortality, and if you look at the map across this country, it's staggering. And some of the areas that you would kind of say to yourself, how is this even remotely possible? But the complexity of having a birthing center is just. I sat through a meeting last week in Vermont, and this was the topic: was how do we as a country address the infant mortality rate in a meaningful way? And there are just so multifactorial issues to it. You have rural communities that can't afford or support an OBGYN, or you can get an OBGYN, but you can't actually get an anesthesiologist to be there. And the cost associated with it, and some of the trade-offs. One of the critical access hospitals was saying to me, survival means I have to do more surgeries, and I only have one anesthesiologist, so if I have them waiting and taking care of OB, I can't have them doing the surgeries that are going to actually sustain my organization. I mean, you think about those trade-offs. It's just incredible. And then think about the need to have a pediatrician there immediately when a child is born, right? And these birthing centers that are, Connecticut has a new push to create birthing centers. We have only one birthing center in the state of Connecticut, and that is directly across the street from Danbury Hospital. Only one. Last year's legislative session, or last year's legislative session, there was a tremendous push on creating and relaxing some of the licensure requirements for birthing centers. And I sat there and said to the director of the Office of Healthcare Strategy, the executive director, who happens to be an OBGYN. We have in our state, we have an OBGYN that runs or leads all healthcare policy and reports directly to the governor. So how's this going to work? Like, do you have birthing centers lined up to open up and actually create this model of care that you've now created a pathway for? In areas where you've seen hospitals in the state, there's multiple hospitals that have applied to end their maternity programs, their whole programs, because they didn't have enough volume to support it. And that's another really important point is, you have some critical access hospitals that are doing 50 deliveries or less per year. How do you maintain the competency of the staff? We just talked a little bit about what it takes. And the answer was, well, we hope so. And so I said, well, so let's talk about that model of care, right? So some people will go to a midwife. Some people want to accept that experience. They want to, really kind of say, well, okay, I want to have a different experience because once upon a time, babies were delivered at home right? I mean, we're going way back. And then when you do that, how do you deal with the complications that come? And we all know, I mean, I don't know what the average age of the women that are delivering babies now, but it seems to me that it's increasing, right? And the longer that you wait, the more chance there is for complexities and high-risk deliveries. And so does that model that we've now really kind of pushed in the state, does it actually address the risk of those complications? And the simple answer is, what I got from the executive director was, you know, we know how to screen, we use all the criteria to screen for high risk versus low risk. We'd only deliver the low risk ones. But the fact remains that you can't know everything, and those complications happen. So the one that we have in Danbury is effective because they have a relationship with Danbury Hospital, and if there is a complication, those mothers that are delivering or babies are taken directly across the street to that hospital. So, and then that assumes that the hospital has a program to be able to deal with those complications, right? So think about that. You're going to create a different model of care in a rural area where you're going to have a birthing center, which isn't going to be able to deal with the high-risk deliveries, and the hospital isn't going to have any of the capabilities. And now when that complication occurs, how fast are you going to get the mother and the baby to the place they need to be? What's the time frame? No more than 20 minutes?
Definitely 25 minutes.
25 minutes, yeah.
If there's an incision for section, and it's that case.
Yeah. I was with the person I serve on a board with is one of the CEOs for the HCA healthcare system. He has 61 hospitals, and we had this debate, pretty in-depth debate about, you know, how can you recreate these models, and he just looked at me and said, you know, Kurt, you can't. You know, you're almost better off creating a transportation system. And in I think it's the state of Alaska, they've actually created a system where, as the mothers get towards the end of the third trimester, the Medicaid program pays for them to now stay in a hotel close to the care that they need. It's a new innovative model that Alaska's trying. Now, what's interesting about Alaska, almost everybody has an airplane and can get from one place to the other, but you don't want to be up in the air as babies coming out. So we kind of all agreed that wasn't exactly the most realistic option. But the fact remains that this country, one of the wealthiest countries in the world, has a major issue with infant mortality. And you can get into all kinds of different discussions about social determinants, where people live, poverty level, all of the things, you know, food insecurities, housing insecurities, literacy, all of those things kind of play into this issue of, you know, a problem that it's like solving world hunger. But it shouldn't be in our country, right? I mean, we're in a country that has the resources to go after and fix these kind of problems, but we don't. So, and then the way we treat and how we deal with those health equity issues is the other, you know, real struggle that we have. Last year, Albert and I were supposed to do a mission to Dominican Republic and visit a bunch of hospitals and clinics. And when we met with the team from there, one of the subjects we talked about was, you know, infant mortality. How do you address, you know, problems and deal with issues? And what was quite extraordinary was the president of the one hospital said to me, well, you know, we're on the border of Haiti and Dominican Republic, correct me if I'm wrong, and they actually take care of a tremendous number of women from Haiti, and literally, so I asked him about compliance, and he goes, what do you mean? He goes, we give those expectant mothers vitamins, and it's like you gave them gold. There is absolutely no issue with compliance. They take those vitamins, they come for their visits, and so the prenatal care is actually pretty good. And when we talk about transportation issues in this country, those women walk. really, really far to get to those clinics because it matters to them, right? And so, look, arguably their infant mortality rate is worse than ours, but they have solutions, and there are many solutions around this world that we haven't really thought about. And the big, elephant in the room is also malpractice, and how do you practice and create incentives for physicians to select OBGYN as a field of practice when cases are going for tens of millions of dollars, and it's a very difficult insurance market right now. So I'm saying all this because I'm trying to kind of put a frame around how complex this issue is and how important it is to our community to have the resources that we have. We have the most extraordinary environment for practice. We have been able to attract and retain OBGYNs. I am really proud of the fact that when you look at the population they serve, it's a diverse population. It's diverse in so many ways. I mean, we have a significant Muslim population that comes here, and individuals, these mothers, these expected mothers, are treated holistically. They're treated in a way that respects their beliefs, their faith, whatever it is. And I couldn't be more proud of the construct that we have here. So the capital campaign to me is, in a lot of respects, very personal, because it's one that really does elevate the environment for not only the team that works to take care of these women, but for the women themselves and their babies. By moving back to the Families Are First birthing center with a C-section suite, it really does enhance. Now, we've not had any issues with taking women from the birthing center to the OR. There have been certainly panicky moments when the elevator doesn't work or something is obstructed, but they've done an extraordinary job of making sure that that risk has been really very much mitigated. So it's not okay to have that risk. I can't say enough about the Rosenheim Foundation for them really coming in here and listening to our OBGYNs and our team, our leadership team, and making a leadership donation of $2 million to really kick us off and get this thing going. As of yesterday, I think I heard the current project cost is about $2.6 million. So this capital campaign is going to bridge the gap. But the other thing is that the team would love to upgrade the interior of the unit and the finishes and all the stuff that's been there. And I think the thing that hit me the hardest was Pat Duclos Miller, who's one of our educators, was the manager of that unit once upon a time. And so how many years ago was that? Anybody know? Got to be 30 years ago at least.
Yeah, I think it was like 30 years.
Yeah.
30 at least, maybe 35.
Yeah, I think 33 years ago.
Yeah.
For sure.
And she said everything looks exactly like it did the day that I was managing that unit. And the other kind of, it's not really funny, but we have parents who come and visit their kids having babies who say, oh my God, this is the room that I delivered you in. It's exactly the same way it is. So
It's clean though.
John, you were...
That's what we said when my two daughters were just, thank God we have our fortunate kids were delivered here. One just turned 4 yesterday, and that's exactly what my wife said.
Yeah. So we're hopeful that we can raise enough money to actually go in and renovate that unit. The internal team, we just opened up the F floor in the hospital, and the first day when we moved in there, I was up there, and there was actually one nurse was crying. She was so so happy and so impressed with how it looks brand new. The transition, the way it was done, was just incredible. We're now finishing up. We're going after to do all of G level, and so that team could do the same thing with very few dollars. They could actually go in and do the renovation, and it's really good to have an internal team to do that because they can work around changes in volumes and flows and things like that, and work with the staff in a way that's much different than if we had somebody come in and just, because you're gonna pay them to go from start to finish. and you got to have it from start to finish. And with the internal team, if they can't do something, they can pull off and do something else. We certainly have a building that needs work in many areas. So this project is absolutely important to me, and important to this organization, important to the OBGYNs and the staff that are here today, who are going to tell you a lot more about it. Hopefully I didn't steal any of your thunder. Just a couple other comments, unrelated to OB, but related to the environment of care, and that is the issue of violence and that's occurring in our environment. Literally every 3 to 4 hours, there's a staff member that's assaulted in hospitals across this country. It is out of control, and there needs to be an absolute change. And it's not just assaulted by hit or punched or kicked or spit on or bitten. It's the verbal abuse that the staff takes that after a while just wears you down. And I don't think anybody doesn't realize how short nursing and all other allied health professionals are in this country. It is just extraordinary time for us coming out of the pandemic. Many people who signed up said, I didn't sign up for this, and left, and we have many have left the field to choose other career paths. But if you think about it, and this is the most important thing that I kind of take away from it, is that if your spouse works in this environment and they are at work one day and they get assaulted, and now they come home to you, what are you going to say to them that night when they come home? What are you going to do? You're going to say, that's it, we can figure it out, you need to get out of this environment. That's the problem, right? Because many of the nurses who were assaulted, almost to a fault, just move on from it. And it goes unreported, and it just builds and builds and builds until it gets to a point of, I'm out of here. I can't do this anymore. Yesterday, so we have really good state laws. Senator Henry Martin has been extraordinary at leading the charge to get the laws in the state to a place where, we are one of the few states in the entire country that has the most advanced protections against, the assaults, the penalties, the process. He's relentless in it. At the federal level, there's a federal legislation that makes assaulting a healthcare worker at the same level as if you were to assault an airline stewardess. Think about that. Right now, that's not the case. So it's called the SAVE Act. It's, as I remember the count, I think there's 143 in the House that have actually co-sponsored that bill. As of last week, not one of our federal delegation had sponsored that bill. I reached out to Congressman Larson, and Friday he basically said, absolutely, I'm signing on to this bill, and it is a priority for me. I'm sure that Senator Blumenthal and others will do the same thing. I mean, it's a challenging time in Washington. Think about the time frame for that bill. You've got one in the Senate and you've got one in the House. To get it across the finish line before the election is absolutely incredibly important, right? It's important because it's a reset after the election. We go into a lame duck period, nothing really happens, and there's really no chance. So the focus and attention between now and November, getting this thing across the finish line, is just so vitally important. So if you have contacts and relationships with our federal delegation, please ask them about their support of the SAVE Act. We need to get it done. We can get it done. I think we need 216 votes in the House to get it done. We're about 60 away from getting there, and there's a tremendous effort across this country to do that. Just a couple more things. We've come through a difficult financial time. We're okay. It's not been easy, but when I look across the country and I recognize there's hundreds of hospitals that closed last year, there's probably 300 more that are in a place of just about closing, and the reasons are really very much, and there was an op-ed actually in the Bristol Press, was it this morning I saw it? It was this morning about consolidation, it was in there. The awareness of the issues is really very much growing. And the biggest issue, of course, is that if you look at us, Medicare is now Medicare Advantage, which most would say is Medicare Disadvantage. It's 64% of our Medicare population. It is horrible to the people on Medicare Advantage. They may not realize it because they haven't had to use the system yet and because it pays for their medications and drugs. But there is so much harm caused by delays in care for these individuals that I just don't understand how, as a country, when the Centers for Medicare and Medicaid Services basically says that one of their primary focuses and what they have a whole organization kind of focused on is not doing any harm. But you don't have to go far to talk to people who, newly diagnosed with cancer, got delayed because they needed a prior authorization, and it potentially cost them months of their life or even their entire life because they weren't able to get the PET scan, all the things that they needed to be able to be treated and taken care of and actually get access to care. Our cancer center has 2 oncologists, just 2. They treat an incredible volume of patients. In 1 month, 360 prior authorizations were required to take care of those patients. We've actually had to add staff to do that. So I would say, and I did a program with Senator Warren 2 weeks ago, and it was focused all on Medicare Advantage or disadvantage abuse. And I listened to doctors, I listened to people. I don't understand, as a hospital executive, and being in an environment where anytime we make a mistake or we do something wrong, it is a stop the line, we report it, we can be sanctioned, we can be sued, we can lose our license. How is it that Medicare Advantage can operate in a world where there's no consequence? Not one consequence for hurting a patient, and they hurt patients every day. So, and I didn't talk at all about the under reimbursement. Medicare pays us about 82 cents on the dollar cost. We make that up on the commercial side. Medicare Advantage pays us 13% less than that. So Medicare Advantage pays us about the same as state Medicaid, and this state has a serious problem with state Medicare reimbursement. They just released a report about 2 months ago, which basically acknowledged and demonstrated all that we already knew. So it's a really difficult construct for hospitals to survive, especially in an independent world. Anyway, so I'll stop there because I want to move on to our panel discussion, and I'm happy to answer any questions you might have.
I'm Dr. Vemaredi. I've been the chief of the department for the last 6 years, and I've been working in Bristol Hospital since 2010. And I can confidently and proudly talk about our department and the services what we are doing. So basically, we are 9 OBGYN doctors, and we work in 2 teams. This is the team which works for Bristol Hospital, and we have 4 doctors who does call, and Dr. Pruitt, I'm sure everybody knows about her. She's been in the community for the last 40 years, and she just gave up her obstetric services, and she's been doing GYN, and that's why she's not in the picture. We didn't want to ignore her, but that's why she doesn't come to the hospital. And we have 4 doctors in this Bristol Hospital group, and our office is in 15 Riverside Avenue. We just moved to the new medical care center, and that's our routine office, and we have satellite offices, one in Southington, one in New Britain, and one in Plainville. So each doctor goes there once a week, and we try to get involved in the community, so we want to just decentralize. And each doctor works 1 day a week in the hospital because we want to be in-house when we are covering the hospital. So the doctor who is on call will be working in Bristol Hospital level C, where the mammogram weekly center is, so we are very much readily available to go to labor and delivery, and we cover the rest of the hospital, including the emergency room and the floor. And this is the women's health group who has been in the community for I don't know how many decades, probably 3 or 4 decades, and these are the doctors who are there currently with them: Dr. Breakstone, Dr. Luango, Dr. Laksha, and Dr. Shea. And they're adding another doctor soon. And their office is in Southington, and that's the primary office, and one of the doctors work in the hospital in 25 Newell Road office, and they cover the hospital. So technically, 2 doctors are there on call with us 24/7, and it's a good support system for us in such a small hospital, having 2 doctors cover on a daily basis. If I have an emergency, I have a problem, I need somebody opinion, I have another colleague, and she comes in to help me if I need help. So that is how our system, in such a small hospital, having 2 OBGYNs covering the hospital is incredible. And the hospitals around have almost gone to a hospitalist model, but we are doing a semi-hospitalist kind of model where one doctor takes care of 24 hours. We are there in-house from 8 o'clock till 5 o'clock, seeing few patients and covering the hospital. But after 5 o'clock, if there are patients in labor, we typically stay back and take care of everything. If there's an active patient, we stay back in the night and stay in the hospital. If there's nothing going on, and everybody lives 15 to 20 minutes away, so we go home, but if there is a call from the patient and labor and delivery calls, we are there in 15 minutes. That is how the whole department works. And if our homes are farther than 30 minutes, we stay in the hospital. And the services what we offer are, I think we offer an entire spectrum of gynecological and obstetric services. Regarding GYN, we offer preventive care, we take care of adolescents, and we take care of GYN geriatric problems. We take care of the fertility issues, we take care of most of the urogynecological problems, and all women's health problems regarding GYN essentially. We do routine office procedures, which is done everywhere, and the services what we have in the office would be like a colposcopy, putting IUDs and implants, removing some skin lesions and cysts. But if these patients need to come to the OR, we do offer an entire spectrum of GYN surgeries also. And most of us are like minimal invasive GYN surgery, so everybody is trained and experienced. So we offer an entire spectrum of minimal invasive gynecological services, which includes hysteroscopy, laparoscopy, and many of us are trained in robotic surgeries, which is the state of art now. So we do whatever needs to be done robotically, we do robotic surgeries. And the traditional art is not lost. So the open surgeries which needs to be done, everybody's trained, and we do open surgeries also, and vaginal surgery. So typically, I think we offer the entire spectrum of GYN care. And regarding our obstetrical services, we deliver at Bristol Hospital, which is a level 1 labor and delivery unit. Because it's level 1, we can deliver only mothers who deliver babies after 35 weeks. But we do take care of high risk and low risk patients, and if there is a patient who comes in labor and needs to deliver right away, though they are, let's say, we have delivered babies who are 24 weeks and the babies get stabilized. We had babies who are 24 weeks with twins, the babies get stabilized, and then the unit from Yukon comes and they take care of the babies. And the mother goes to the baby once she gets stabilized. If it's a vaginal delivery, maybe a few hours. If it's a C-section, maybe the next day morning. We try to transfer the mother so the mother is with the baby. So that is how we manage the unit, though we are level 1 unit. And regarding how we take care of these pregnant moms, we take care of low risk and high risk patients. So the beauty about Bristol Hospital now is we have doctors from Yukon, the maternal-fetal specialist, who comes here once a week. Thanks to Kurt, he brought somebody once a month 10 years back, but now the services extended so much that they're coming once a week. So all the ultrasounds are done by them, whether it's a simple obese patient or simple diabetic patient, they give a consult. And it feels like I don't have to send anybody to Yukon. And if I'm seeing them in my office, and if they have to be delivered before 35 weeks for some obstetrical reason, they already know the doctors there. They have the high-risk doctors who've been watching them in the ultrasound, so they are comfortable going to Yukon. So for me, at this point, I have no reason to send anybody to Yukon unless they're really, really complex and they should not be delivering in Bristol, and if I know that early. Example is like somebody who had prosthetic valves or somebody who had multiple heart surgeries and should not be delivered in a regular hospital. And that kind of person, I would transfer to a tertiary care center. But otherwise, I think we have an entire spectrum of care here where everybody can be taken care from the time they conceive until they deliver here, whether it's a high-risk patient or a low-risk patient, because we have the doctors. We collaborate with the maternal-fetal specialist who is giving this the concept. And I think that is, it is a great advantage we have here. At the same time, I want to say that we are no lesser than any tertiary care hospital. The care we provide here, everybody is an MD. There's no mid-level providers. This is not a teaching hospital, so there's no resident taking care. And the most interesting thing is we follow our patients for every visit in the prenatal care. So if somebody establishes with me, I'm going to see her every month unless I go on a vacation. My colleague sees. So that's an opportunity to meet my colleague. But otherwise, she is connected with me. There is continuity of care and there's patient satisfaction. And we proudly tell this. I don't think this is offered to pregnant patients in any other hospital. And because we don't have the hospitalist model, the hospitalist model is somebody sees them in the office, a hospitalist comes and delivers. So they have no connection between this group and this group. And they don't know who is going to be there. At least here we are like, they know the doctor and they know my colleagues. And they know that, okay, I'm on call on Mondays. And if I deliver on a Monday, this is going to be my doctor. If I deliver on a Tuesday, I have my colleague and they know who's the doctor. So that kind of care, I don't think any other hospital around us is providing. Even the smallest hospital, if I'm not mistaken, Mid-State also is going to the hospitalist model. They are looking for the hospitalist model. And Bristol Hospital is not yet there. We feel like we like to take care of our patients this way, and this is more patient satisfaction. Moreover that, I think if I follow my patient for 9 months, I know about them very well. I'm not going to miss anything. So I feel like this is a better care for these mothers, and we love what we do. And that is what I want to proudly say about our practice. And that is what the Women's Health Group also on the other side do. There are no mid-level providers and there's no residents, and that is the biggest work. And we are all women, and moms want to be delivered by women in these days at least. So that, I think this is the beauty of Bristol Hospital. We have a lot of patients around who prefer women providers, so that is why they tend to transfer here. And I want to tell you that we have a 24-hour, Kurt was talking about anesthesia, we have a 24-hour anesthesia coverage. If we have patients in labor and there's an emergency going on from surgery side, they have a backup to come. So a second person comes here to give as a backup, and they're half an hour away and they come and give an epidural. So we have that kind of backup for the whole hospital. We have a pediatrician who's in-house all the time, 24/7, and that is something like to talk about volumes, how much we care about our mothers and the babies born here. So I think I feel like this is the best setup for a hospital, and I think we are no lesser than any tertiary hospital. And 20 minutes away is Yukon, so if somebody has to be transferred, we can transfer them there. We have physician assistants who assist for our surgeries, and they're in-house also all the time. And if we have a complex case, I have my colleague who is there on call, so I call them. So that is how our unit works, and I feel really proud to talk about my department. Anybody has any questions about our services? Before I give this.
How many babies on an average do we deliver a year?
So a year we've been doing around 600 deliveries. I don't think our unit can occupy more. I let Chris.
We could easily go to 1,000.
Okay.
I just throw that out.
If it goes to 1,000, it just.
No stress.
Okay. Yeah, I wish we can do the 1,000, what Kurt has been asking for the last 15 years, but I don't know, when it comes to a month where we have like 70 or 80 deliveries a month, it just gets crucial with the space. But yeah, we are not yet there, but we'll love to have that going.
Well, I mean, it's dependent upon the overall birth rate of the population.
Yes.
Connecticut clearly is going the other direction. So the fact that we've maintained is really a very incredibly positive thing.
I just want to thank everyone for coming and taking the time out to listen to us brag about our unit, and for Kurt allowing it. We're real passionate, all of us, about what we do. I have only been at Bristol Hospital, it'll be 2 years in September for me in this position. But I have worked at other hospitals in their labor and delivery units, and I've been a nurse for 34 years. So I've seen a lot, and I've seen a lot of the way a lot of hospitals work and run their OB units. What drew me to Bristol was the culture. I really got a good feel when I interviewed with the doctors. I interviewed with the staff as well, and I really, they had a lot of staff with longevity. Unfortunately, right before I came, they had a mass exodus of nurses that were here for over 40 years. But we have a great mix now, and the younger nurses that are coming in are doing a fantastic job, and are very passionate about labor and delivery as well. So our floor has 13 labor, delivery, recovery, and postpartum rooms. So what we in the business call LDRP. So it's a different model. There's different models in OBGYN. Some hospitals, the larger hospitals, have separate delivery suites, and then postpartum you're on a different floor, and nursery is different. The LDRP model means that everything is done in the same room. So you labor in the room, you deliver, you recover, and then your remainder of your stay is in that same room. Most of the time, we try and encourage the babies to stay in the room with mom as well, which we call rooming in. So that allows us not to open and staff a nursery. We can keep all of our staff on the floor. That also helps staff to patient ratios. So we use AWON, which is the Association of Women's Health, Obstetric, and Neonatal Nurses, as their guidelines for our staffing model. And we can proudly say that we adhere to what they recommend, which is a 1 to 3 couplet ratios postpartum. So if you don't have couplets, you could go to a 1 to 6 ratio total between moms and babies. And then in labor, it's 1 to 1. So a lot of other hospitals that just do the labor can sometimes do early labors, together, but we like the 1 to 1 ratio, that building that rapport with that patient, staying with that patient through labor, staying through recovery and into postpartum is really a great thing. We have a permanent charge. Darlene is our permanent charge, 4 days a week. That's wonderful because we do a huge outpatient population testing. So she is in charge of that. She sets it up. She works very closely with all of our physicians with getting their patients in here, booking their appointments. The process is very streamlined. If they have to come a couple of times a week or weekly and they have all these recurrent visits, after their first visit, the process is so easy. They come in, they register with our unit secretary, and hopefully we can get them in and out of here in a timely manner. We have 3 nurses on our floor still that have been employed for over 35 years. They're great preceptors to the new nurses that are coming in. We have 15 nurses with their bachelors of nursing and 2 nurses with their master's degrees. We also have 7 nurses with certifications for obstetrical. So it's either fetal monitoring or inpatient obstetrics, things like that, lactation consultants. We have 2 nurses that have that are employed with us. We don't have on staff per se lactation consultant position, but we have nurses that are certified in it and are lactation consultants. So they get that for, as part of being and delivering here. We have 3 nurses that are actively pursuing their certifications at this time. With certifications, you have to be practicing in that area for 2 years before you're even eligible to take the certification. So some of our newer nurses, once they reach that spot, will also pursue. Bristol's really good about encouraging continuing education and supporting their nurses in doing that. And so we have, most of our nurses take great advantage of getting that certification and with the hospital's help. We have 20 per diem employees that help out and come in from their other jobs, and they love it here. They love the culture as well, you know. They like coming here and seeing our diverse population, and it's a lot different than the bigger hospitals that feel more like a factory, where here feels more like home and family. We've had multiple Nightingale Award recipients, 4 that are still currently working with us, so that's great. And then our nurses, like Kurt said, it takes a year, almost a year, for them to just orient, and that's probably not even discussing until they feel real comfortable, you know? It's probably a good 2 years until they really feel comfortable on their own. And that's because they have 5 different areas that they need to train in. So they train for the nursery area to be able to care for the babies. They have to all be certified in neonatal resuscitation. Then we do the postpartum areas for mom. Those are usually the first 2 areas we train anybody coming into our unit in. Then we go to labor. They need to be trained in labor, which is a big majority of their training, because they have to do the fetal monitoring. They have to be able to interpret that. They have to know what a healthy baby looks like on the monitor and what's not so healthy. And then they need to do the OR piece. So they need to learn how to circulate and be in the OR, and we are an umbrella of the main OR, so we have to follow all the main OR's rules for our rules. So it's very complicated, and they're probably the most certified nurses in the hospital, because they have to be certified in BLS, your basic life support. We are now training to do advanced life support, so that we can be on the monitors when we recover our own C-sections. They have the fetal monitoring certification, and they also have to have the neonatal resuscitation. So there's a lot of certifications and learning that goes on with our nurses. All that being said, they have satisfaction levels that are consistently above the 90th percentile. And what I try and tell them all the time is that is a very hard feat to accomplish. And the reason I say that is because childbirth is a great thing, right? And it's usually a very happy time. The expectations of our patients when they walk through the door is a lot different than a sick person that comes to the ER. A sick person that comes to the ER is going to feel very grateful for everything that you've done for them. Whereas our patients come with birth plans. And when those birth plans cannot be seen through to the end like they want it, they're disappointed. So it's very difficult to keep those satisfaction levels high. I had to laugh, and I have to tell you, my son's friend just came in a few months ago, or last month, and delivered. And he said to my son after, he goes, well, Mike, I have to tell you, your mom, she must run a tight ship. And he started laughing, and he said, why? And he goes, because everything was perfect. We couldn't have had a better experience on that floor. And this was their 3rd child. So that spoke volumes. Our nurses love what they do, and it shows in the care that they give. And I think it starts from the top, because Bristol Hospital likes the shared governance program, and they want their nurses' voices to be heard. And we have a strong shared governance unit on our floor, and Darlene is the head. So
Yes.
I'm going to hand it
Yes.
off to her, and she can explain that
Talk a
model
little bit about shared governance. Shared governance, I became involved with shared governance in 2014. I was co-chair with another nurse on the floor. We didn't know too much about it. We just know there was something about the nurses and being heard and just to activate some plans. For the past 5 years, I've been the chair of shared governance and have loved every minute of it. It speaks to nursing in a way that no other organization does. What we do with shared governance, the mechanism of shared governance on Families Are First is to empower staff. And when I say staff, I don't mean just nurses. It could be our techs, it could be our secretaries, it could be the housekeepers on our floor. We incorporate everybody with shared governance. All decisions and discussions made are staff-owned and organizationally supported always. Being a chair, it's been a challenge to have a meeting every month, and COVID did not help that. So what I decided to do was, instead of having organizing a meeting and having the same 3 people attend the meeting and wondering what a topic would be about, we decided to do impromptu meetings. And at that point, it was, and we even just today, we're talking about something that Julie just said is going to come to shared governance. Every other day, somebody says this is a shared governance issue. What I do is we have a small meeting, we devise an action plan, we send an email out to all staff on Families Are First, so everybody can voice their opinion, and when everybody's on board, we make a change. We also incorporate some of our physicians in our shared governance, and I don't have enough time to tell you all the things we've done, but I picked a few of them. One of them was with Dr. Vemeretti. We have, as we said, we had a big turnover of nurses, and we have new grads and new nurses coming from different areas that may not have as much experience as the rest of us do. So, and it can be quite intimidating when you're not going through a first or second or third year resident to get to your primary doctor that you want to give a report to. So some of the new nurses were a little anxious, calling the doctors in the night and during the day. So we had a shared governance meeting about it, because the nurses came to me. And Dr. Vemeretti also came to me saying, you know, some of the nurses, they're just getting a report that's not very clear. We got together, we formulated a plan, and the SB of the SBAR reporting was emphasized, the situation, the background. Dr. Vemeretti then took the time to pull nurses aside to teach them what needs to be said in a report, what's important with that postpartum patient. So that was instrumental in Doctor's part, and we were very grateful for that. So that was part of shared governance. Another issue was high-risk hemorrhage. All the nurses got together and said they were going to devise a kit to bring into the patient's room. Should a patient hemorrhage, they have it right there. Some of the doctors prefer us to draw it up and have it ready to inject, and we also, you know, discovered that that was a wonderful plan to have. Back to, again, the new nurses, neonatal resuscitation. They do not learn this for about 6 months, maybe, into their program. So we collectively had a group with our head of pediatrics, Dr. Labella, and said our nurses are feeling a little insecure. They walk into a room, what do they do if a baby's not breathing? Dr. Labella, with some of the staff, formulated a plan to have a 1 or 2 hour session with all new nurses coming in to teach them what to do if that baby's not breathing. So it's very exciting. Then back to just to make the nurses happy. Recently we had a whole complete workstation developed just to ease the flow of the nurses station. The doctors think that they own it, but it was really for the nurses. So we had to get all the departments involved. We had an electrician, we had maintenance. We talked to everybody about things, and we have a beautiful nurse working station to ease the flow. We connect with anesthesia. Shared governance is it. We're working. Julie just mentioned. What did you just mention to me that we had to bring to shared governance today?
We have to track how many moms do not want their babies at night.
So that's a shared governance. So then we'll bring that up to a meeting. We'll discuss it with the nurses. And we always incorporate Julie because she is our manager and she's very supportive. If we have an idea, because it may be a budget issue, it may cost money to get a workstation. So we have to get the okay for the powers to be. And so we always arc it up. But I love shared governance. It's the best thing that's happened to nursing. I think in my whole career, and I've been a nurse for 39 years and been here for 37 years. So.
I'm going to keep that part of this video and use that because you just did such an incredible job of describing shared governance.
Oh, I love it.
The other thing that I think is amazing is the use of, you guys will look at data and research.
Yes.
It's not just drawing on the physicians and everything else. You want to find best practice.
Right. Best practice, always.
And when I think about the profession of nursing and the commitment that a nurse makes to continual learning, and what you do to really bring the best and most current stuff to the table in every environment in this organization, it's just extraordinary. Yeah. I wish that we could do that for every profession within the organization the way you do.
It's very motivating, and we have a responsibility to the newer nurses coming in, and we started there's a new grad program. When I became a nurse, you had to work med-surg for 2 years. You had to find experience somewhere else, but now we have a new grad program, so we have nurses right from college coming in. But we need to support them and keep them, and so shared governance is a way that I bring them into the fold. So I'm really excited about it. If you have any questions about shared governance, I'd be happy to answer. We just don't have enough time to tell you all the good things we've done.
Okay, so as part of our inpatient obstetrical services, so we perform approximately 600 deliveries a year, 30% of which are C-sections, which align with the national average. So the national average is also at 30%. And approximately half of those are emergent. And then there's a good portion that are repeat sections. We do vaginal births, assisted delivery births, which is vacuum or forceps, VBACs, which is vaginal birth after cesarean. Those are only able to be done because we have the in-house anesthesia and pediatrics programs, because they are a little more high risk. And then C-section deliveries performed as well as tubal ligations at that time. Again, Dr. V spoke to our high-risk obstetrical care for patients over 35 weeks. We can deliver them, and that includes hypertension, which is one of the biggest factors for increased mortality and morbidity with maternal issues, preterm labor, gestational diabetes. Those are just a few of the things that we care for and deliver. We also, one of our nurses has taken a passion for helping moms that have had fetal demises or stillbirths. We take a very sensitive approach to that. One of our nurses, Megan, who is actually our Nightingale winner this year, went out on her own and actually took a special photography class so that she can incorporate photos into the memory boxes that we supply them. And we've also talked to the ED about if they have infants that come in, that we have these boxes available for them as well, for any deaths for infants, toddlers, things like that. It's a hard topic to broach, but afterwards it means so much in the healing to these moms. And we do a phenomenal job with that. We actually received grant money this year to help with adding things to those boxes, like the forms for their handprints instead of just the ink pad, but they can now do like the ceramic handprints, things like that. So that really helped a lot too. And Megan was really excited that we were able to receive that. And we also have a Little Loves Library, which is a program that was established by a woman who experienced a loss, and that focus is on supporting the bereaved parents and siblings as well, because they don't understand, especially if they're young. You know, mommy had a baby in her belly and now she comes home without a baby. So these services really, really mean a lot to our patients that happens to. Thank God, it's not often, but we do have them available if needed. And those are some of the obstetrical inpatient services, and Darlene will go over.
I don't know if you need to change anything there.
Yeah, the next slide.
Certainly. Okay. So inpatient newborn services, we have a level 1 nursery, but we can care for a baby who is infected. We do IVs, antibiotics. We can do cardiac monitoring on a baby. We can do pulse oximetry on a baby. Babies can be on oxygen with us, so that keeping the unit together with mom, dad, baby, or partner with baby is important. So we can utilize our nursery that way. And then we also have our partnership with UConn if we have something that needs an infant needs a higher level of care. We currently, follow the guidelines of DPH with our Connecticut mandated newborn screening, hearing, cardiac screening, and we also have information we provide the parents to explain every procedure we're doing on their baby, so they are very well informed. We do car seat testing. These are for babies that are under 2,700 grams or 36 weeks and less. It's just to guarantee that this baby can be in a car seat for a 90-minute period or however long the parent is, if they live 2 hours away, which isn't often, that baby can maintain its oxygen level and not have any compromise in its health in a car seat. And if it does not pass, we provide a car bed and then have them come back as an outpatient for car seat testing, usually within a month. We established years ago the Happy Birthday Baby celebration, and siblings are included just to celebrate the baby's birth. And that's gone over very well, and patients are very excited and ask for it when they come back the second and third time with their babies. And then there's another screen. That's about
Yeah,
it for that.
that's for the inpatient.
That's
Now,
inpatient.
Outpatient services, this is our biggie.
Yeah, this is fetal monitoring for high risk, as Dr. Bemeretti said, and as Julie elaborated on. I do all the testing for high-risk patients. I do fetal monitoring for our hypertensive, our preeclamptic being pre-seizure. They are very high risk for rolling over to that category of hypertension. Diabetic mothers, many high risks. I see these patients once or twice a week, anywhere from as little as 4 weeks to 10 weeks. I get to know these patients very well. I'm kind of the connection between the office and our floor, because I do have the time to get to know them. I have to minimally have them on a monitor 20 minutes, and it could be a maximum 4 hours that they're on a monitor with me. So we do get to know each other. That is the second part, is the non-stress test. That's just the test that I have to do on the patients. I do all the labor checks, the preterm. If we have a mother comes into labor, if she's not going to deliver, she's preterm, I will organize with the doctor our transfer to a higher level of care, and that goes without a hitch. We do not have an issue with that at all. I do a lot of injections, ROGAM, Tdap, always available for that. We do external versions on the floor. That's on an outpatient basis. That's when a baby is head is breech, and the doctor will come and turn the baby, but it's a process that we have to collaborate with anesthesia. And it's a 2-hour type procedure. And that's beneficial for the parents when the baby does ver over. I participate in the iron infusions for our anemic patients, so that makes it easier for them to come in to have that done. We work with all the other, I also work with all the other units of the hospital. If we have a patient that is transferred to the ICU for some reason post C-section, we go up and collaborate with the nurse. I go up and collaborate with the nurses to educate them on fundal checks and hemorrhage, and if they are still pregnant and should be on another floor for another reason, I will go and sit with the patient and do fetal monitoring and talk to staff about that. So we have a very good relationship with all departments. There was how close we get with patients is Dr. Bemeretti will occasionally call me and say she has special patients, a husband and a wife team, or doesn't matter, just a partner team. And I recently had them, and they're just not familiar with the hospital environment. So she'll send them to me, and I will do a private tour with them, and I will sit and talk to them. And many times they come from a different place, a different country. There could be a language barrier, and we have an excellent translator system in the hospital. And I get to know them, and then what's nice is, because I'm an outpatient, I do all the outpatient triage. I also attend every birth of a baby, so on the floor. So these two couples that came in and I got very attached to, I was there for the birth of their babies. And then when they needed resources, Bristol has a wonderful diaper connection resource where people can get diapers until their children are out of diapers through our town. So I connected them with that because they had limited resources. And I got very attached to them, and it was just a wonderful experience. The doctor likes to call me every once in a while, right? You'll have just patients that
I
she
don't
just...
want to say anything less about how we do, is because everybody, from the time they get to the office and by the time until they deliver, their path to the baby birth is like such a beautiful experience, because they're not lost. They see the same doctor, and once, if there's any high risk, or even if they don't have high risk, I try to get them to Darlene so that she can show them the labor and delivery. They'll make them comfortable, and it just feels like you're coming to your second home. By the time they deliver, they know everybody around.
Oh, yeah.
They know labor and delivery unit so well, and they know half the nurses already. So they just feel, look, nobody's asking me where to come, when to come, and all. They know everything by then.
Right.
So I just feel like that this kind of services is so personal to everybody.
To
I
add to
really
that
feel
for
proud about
Darlene,
it.
she's the charge nurse, and Darlene is our eyes and ears. Because if I'm delivering Dr. Bemeretti's patient, Darlene knows that patient more than I know the patient, because she's another doctor's patient. So I would go to her and I would ask her, I don't have a good vibe, and she would calm me down. Listen, this is the language barrier, just go and spend another 5 minutes and you will realize. and it changes the whole atmosphere. So we are blessed to have the nurses we have,
Yeah.
and incredible job that these guys are doing. So yeah, thanks for our eyes and ears.
Thank you. Thank you very much. So just to keep going, the outpatient on infant services we have, babies many times will not pass a hearing test. We welcome them back. We work and we do their hearing tests. We have a physician that does frenectomies. If a baby is born with a tongue tie and they have difficulty with feedings, we have a doctor that, it may not be the right time for them to have that procedure done in-house. They will come back and very happily do that also. And we do circumcisions on an outpatient basis if a baby's born really small. We give them a month to grow, and then we'll do a circumcision. One of the biggest things we do is we do fetal bilirubin testing. All of the babies on the outside from different practices. I even had one of the pediatricians, Dr. Januzzi, called to say, do you mind if a patient comes for this? Because when they go to Yukon or somewhere else, they have to wait, and they're a number, and they don't know anyone. And we welcome that group to come in, and they just come through the front door, come up right to our floor, and myself or another nurse will do the testing for jaundice. I will tell you at the end of this, it does say Sarah's story. Sarah Galloway is a nurse that came to us about a year ago. She was a travel nurse that loved our floor so much she decided to apply for a job, and she took a job on our floor. And she was, her main home was Yale. So she came on our floor, and she's got a day job, and she's wonderful. And there was a given day, I'm not sure if it was about a month ago or so, but we had a baby come in for a bilirubin. Standard test we do, we talk to the parents, and this was a baby that was born in another hospital. So the baby stays in the car seat, and she's doing the blood, and she noticed the baby's bleeding a little slow, and she's touching the leg, and she realizes the leg is very cold, and she called myself in and another nurse to say, what's going on? We start talking to the mother, putting her at ease just to say, how's the baby feeding? She said the baby's hasn't been waking up for about 24 hours. Well, and our antennas go up, and we realize something's going on, and we just said, we're going to check a temp, and the baby's temp was less than 90 degrees, and that is very critical for a baby. Unless the baby's on an ice block, that is a sign of, could be pending doom, infection. We called our pediatrician in-house, Dr. Cavley, to come in. We did a full septic workup with a lumbar puncture, and this baby was transferred to a higher level of care, and this baby was found to have septic listeria. And this baby probably would have died within 24 hours of this being found out. And why I say it is because, not just because we take outpatients in for testing, we get to know our patients. And that little baby, for the 10 minutes of that blood test, we got to know that baby and talk to mom and to dad, and what the keen nursing that Sarah applied to her assessments saved that baby's life. And Sarah was then awarded the CHA Healthcare Hero Award for this year, so we're very proud of her as a new nurse on our floor. And that's Sarah's story, and that's a life-saving story.
And it's called Connecticut Diaper Connection, and that started to be established at Bristol Hospital right before I started. So Lisa was in the midst of getting it all set up when I started. So it's been a little bit since we were able to get it up and running, but we partnered with WIC and Bristol Community Services, Youth Services Program. So we didn't have a place to store the diapers, receive the diapers, and pass them out. So that's their portion of it. So we refer any patients that are needy to go and speak with them. A lot of them are referred already through WIC. Some of them have already established a connection because they not only supply diapers to the newborns, they also supply it for older children in the house that are also in diapers. And then we have a Read to Grow program, which will be supplying books. And then we participate with the Bristol Burlington Health Department to do community baby showers and things like that. As far as what we do for the community, we in the last year have reestablished our in-person prenatal and perinatal classes, which have been a great success. So we do birthing classes, which consists of, it's a 3-hour course, and it covers the labor and delivery process, including a brief discussion of C-sections and inductions, as well as the immediate postpartum period. We offer breastfeeding classes, and that's done by one of our lactation consultants. And she does a 2-hour course, and it teaches expectant parents how to provide human milk for their infant, discussing options for feeding, such as direct nursing and pumping. And then we have a newborn basics class, which is a 2-hour course which teaches expectant parents how to care for their new baby, including feeding, diaper changes, swaddling, infant safety, and much more. So all those classes you can access online, and you can sign up online, and it seemed to be so far being received really well. There also is a combined class that's split into 2 days, and it covers the entire birth process, including postpartum care and infant care, newborn care, and breastfeeding. And it says each course is 2.5 hours long. So we've done a lot to kind of get out there to the community and, show them what Bristol Hospital has to offer. And we're really proud that those are back, and actually our educator for our floor is also one of our clinical nurses. So she spends most of her time as a clinical nurse, but she also does the education piece. And she's actually established really great connections with the Bristol Burlington Health Department nurses, and they work a lot, and they feed off of a lot of each other, a lot of information. So we're really excited that we were able to get her into that role. And then our accomplishments and future enhancements. So we're excited we were able to establish procedures to address the maternal morbidity and mortality. We're continuing the Save a Life campaign, and that includes education with our emergency department staff. Because we now know that maternal mortality can happen up to a year after delivery. So they've extended that from a 6 weeks period, which they used to think. They've extended it now up to a year. So it's important that our emergency department staff know what to look for in somebody that's been pregnant in the last year for when they come in. And then we have been designated a Blue Distinction Center for Maternity Excellence by Blue Cross Blue Shield, and that's been quite a few years now that we've received that designation. We're home to a Nightingale Award winner this year, Megan Dean. We have a Healthcare Hero Award recipient, Sarah Galloway. We've reestablished a part-time unit educator, so by doing that, we've able to create, we've established more unit drills, not only for the neonatal resuscitation, but for all emergent procedures, which could be shoulder dystocia, it could be a postpartum hemorrhage, it could be hypertension leading into eclamptic seizures. So all of this continuing education has helped the confidence in our staff rise. The unfortunate thing, or fortunate thing, depending on how you look at it, about working in labor and delivery, and I try and tell all the new orients that come in and the new nurses that come into this unit, you could work for years without seeing a cord prolapse. So you could work for years without seeing a hemorrhage, although they're a little more common, but you're not going to always see everything during your orientation. So it's hard for them to grasp what happens during those orientations, right? So it's really important to do these unit drills to get them comfortable, because they may not ever have to participate in a baby code for years, and then all of a sudden it happens. So it's very important to establish these unit drills. We've also established a Policy of the Week program, just to make sure if something happens that people are aware of the policies, they're aware of where they are, but just to be up to date with, okay, if we have an incident happen, we'll send it out. Let's send that policy out. Maybe everybody needs a refresher on just how to handle things. So that's been really well accepted. And then we have restructured the orientation program to kind of make it a little more fluent. And then of course our biggest thing is our new C-section suite and the LDRP room renovations. We're really excited.
There's no doctor who came and left here. We all came, we stayed here, we continued to work. So nobody was unhappy and left to another practice till now since I've been here. Doctors have been here, everybody has got like decades of experience. The CCOG, the Women's Health team has been there for 20 to 30 years, and Bristol Hospital, I was hired 15 years ago, and all my partners who are here joined me and nobody left. We are here, we are a team, and I think we work so wonderfully, and that speaks volumes about how our department functions. And I think we take this too much for granted because when we go to another place, it's very hard to get this kind of environment.
Because we've got $1 million to raise, and
We'll do it.
and we'll take the support. And I know this community always steps up. This is different than the last campaign. This is a really unique and special ask, and I'm sure we'll not only achieve the $1 million, but we'll exceed it. So, thank you all. Have a wonderful day.
Thank you.